Concept of healing time that we talked about. Even with the ankle ligament injury, there's a healing time that's got to be respected, and in the hamstring that gets lost, and people try to return from a acute hamstring injury too quickly and they get re-injured, then it becomes chronic. The mechanism of an acute injury, it's usually an acceleration. So the player, it's typically a footballer or rugby player or soccer player, and they're trying to stretch out and accelerate. Occasionally it's an acute slip or something like that, but in running it's usually acceleration or trying to speed up. When it's an overuse problem, it's generally in the tendon rather than in the muscle, and we'll talk a bit more about that when we talk about chronic. But for an acute injury, the location is really crucial. It really goes back to knowledge of the anatomy, and there are certain patterns of acute tears that if you recognise them, you'll understand the prognosis. In general, the higher the injury is up towards the ischial tuberosity, the worse it is, so the worse the prognosis. And the mid-belly ones tend to be the lower grade injuries, and they tend to heal a bit quicker. So they become recurrent, usually because the severity is not recognised in the first place, and that leads to people trying to get back too quickly. It depends on the person, what are their goals and their expectations. Are they a professional athlete that needs to be able to get back quickly in a week or 2 weeks to be able to earn their living? We'll talk a little bit about the Sally Pearson, Usain Bolt sort of scenario. They both had a hamstring injury leading up into the selection trials into the Olympics. One obviously made it through and the other one didn't, and we'll actually discuss why, and it's really about the anatomy. So the location matters, and the one that's really interesting is the central tendon injury in the biceps femoris. So that's this. Here's an MRI. Let's see. Okay, that's the central tendon of the biceps femoris. Remember that you've got a short head and a long head, and they join through a central tendon that goes up into the ischial tuberosity. So the typical tear that you get there is like a zipper that's unzipped all the way up to the ischial tuberosity, and this is the central tendon injury, and that's the one that's really severe and takes forever to heal. The length of the tear seems to matter to the prognosis, so the longer, they can actually measure the length, the volume, the width, but it's the length of the tear along the hamstring that seems to affect the prognosis the most. When it's tendon, the higher up it is, the worse it is. And complete ruptures, so Nick Rewald, I'm not sure if you remember, he got a complete rupture of the hamstring. When he went to accelerate, he just collapsed on the ground. That was a complete proximal rupture, and he had to have surgery to have that repaired. So what happens with those complete ruptures is people can sort of manage, you know, they can recover and they can walk, and eventually they can sort of, the pain goes away, but they're never really able to run properly with a complete rupture. So if they're an athlete and you suspect a complete rupture, you'll see a deformity. You'll see the muscle bunching up in the middle of the thigh. They are going to do much better with a surgical repair. So what happened with Usain Bolt, I mean, the story is that he had a grade 1 hamstring injury coming into his selection trials in Jamaica, so he said he wasn't going to compete in the selection trials, he was going to rest through the selection trials and do his rehab and recovery. And, you know, obviously he made it, and he got through the 7 weeks, or it was until the Olympics. The opposite situation was Sally Pearson. On her MRI, there was a central tendon lesion, so that was it. Like, there was no chance of her being able to even compete in the selection trials here in Australia. Normally, those sort of central tendon injuries are a 3-month scenario, so they're very, very prolonged, and it's important to recognise those early. So they're the ones, you know, that's why the imaging is really, really important in a high level or elite athlete. And then the imaging can also tell you whether it's localised to the muscle or it's to the tendon. And it's those proximal tendon injuries right up high near the ischial tuberosity. You can get tears in the tendon, and then you'll get tendinopathy and tendinosis, so scar tissue up high in the tendon, and they tend to become chronic and become recurrent. So can you see on your what you're looking at, the deformity in the middle of the belly of the hamstring there? You see that when you ask the person to contract their hamstring, you see that deformity. So the acute injury there, you'll often, the extent of the bruising and the swelling is not always an indication of how bad it is. It depends how it's managed. Like we were saying with the ankle sprain, the ones that bruise up and swell the most, they're often not the worst ones. It's the ones that rupture, they don't often hurt that much, and they're not as dramatic. But the bruising typically will come out in a few days. It'll go down the back of the thigh, down the leg, and you want, in the rehab, you want to disperse that bruising early and get it away from the site of the injury. So the formula Pricer, in the context of hamstring, it's sort of been replaced. Instead of rest, the approach now is optimal loading. So you actually want to get that person moving and walking and off crutches as quickly as possible. And the prognosis, if that person can walk pain-free within 2 or 3 days, the prognosis is a lot better than if someone's on crutches and they're really immobilised for much longer. So the quicker you can get that player walking normally, the quicker that person will recover. And there's good evidence behind that, some studies by Price Warren. And the rest of the rehabilitation, the modern approach to early hamstring rehabilitation has moved right away from treating the single muscle to treating a whole athlete. So instead of focusing on stretching the hamstring or massaging the hamstring or trying to strengthen the hamstring in isolation, there's a lot of functional skill drills, trunk stabilisation drills, bridging, different things like the arabesque things. And this was a sort of approach started in 2004 with the first article by Sherry and Best that compared a traditional approach to hamstring rehab with this very functional approach targeted at the whole body. Superior results with a neuromuscular retraining of the whole body and a quicker return. And then the second sort of revolution in hamstring rehab, for a while it was all about eccentric loading. In the 80s and 90s, it was all about you had to do eccentric and that sort of thing. But that kind of got replaced more with the functional task and then the lengthening work, not necessarily eccentric contraction, but controlled stretching. So that's Askling's work in 2014. And these different approaches really were aimed at preventing the recurrence, because people would come back from hamstring rehabilitation and they get a second injury very, very quickly. And that was very frustrating for the athletes. So these sort of approaches where you're using these weird kind of exercises like the Nordic curl, which is that picture down the bottom left, holding the legs and the players lowering their body and doing a pretty intense eccentric contraction of both hamstrings. And it's a lot about gluteal rehabilitation, because people will overstress their hamstring if their glutes aren't firing in the correct sequence or if their glutes are underactive. So you can read about the rehab. I've got a list of all the authors you need to chase and have a look. But there are a lot of different aspects to this now, and it's a pretty interesting, exciting area of rehabilitation now. So you've got to look at these are the sort of main authors in that. The rehab, the Sherry and Best, the Askling, and Heiderscheid is another one. And a lot of really terrific Australian authors involved as well. And you should also chase up Peter Bruckner's articles. A lot of his are about an earlier return to sport. Yes, sir?
Is there much research about, especially for like proximal hamstring tendinopathy, especially initially, like avoiding compression of the tendon?
There is more. We'll talk about that a bit more in a minute. That seems to be the buzz area now in hamstring rehab, because it's recognised that a lot of these recurrent ones, why somebody keeps tearing down lower, is dysfunction in the proximal hamstring tendon, and you're right, compression is a big factor. And a lot of exercises that we have been used traditionally have a hidden compression element. It's not obvious. For example, certain ways that you do a squat exercise or a deadlift exercise can actually put compression on the tendon, which is counterproductive. So that's another pretty exciting area, and that's the new frontier, definitely. And then there's the stuff about imaging that's really in the world of professional sport. You know, a player with a hamstring injury will have an MRI straight away the next day because they'll look at that imaging, and that helps us give an idea of the prognosis or how quickly that person is likely to get better. Okay, moving on to the next thing, which is the hip. Okay, it's a huge area that, like FAI and the labral tear, is only one of the possible causes of groin pain. If you count them, there's probably about 60 different diagnoses of groin pain that could happen in athletes in particular. But the most common cause of groin pain is a simple adductor strain. So it's usually adductor longus. And the problem with adductor strain, in a similar way to the hamstring, is people want to come back too early or before they have restored full strength and full range of motion in the hip and full strength in the adductors. And the typical scenario is they'll get a mild adductor strain on one side, they try to go back and play the week after, they'll either re-injure that area or they'll get a mild adductor strain on the other side. That starts to shut down their neuromuscular, their performance in terms of how well they can move. Then they'll either tear the muscle worse, or they'll start to get problems with the hip joint mobility, and it can lead on. And eventually, one of the reasons people get osteitis pubis, which it's really a bone injury, it's bone stress, is because of the restriction of movement and the restriction of strength of the simple, first-time adductor strain. So it's up to you as the physio looking after that young player who strains their adductor the first time to educate them and make sure they understand that to prevent them getting really chronic problems, they've got to do their complete their rehabilitation. Don't just do halfway. I said to you guys on the first day, the pain is not really an indication. It takes longer to heal and longer to rehabilitate somebody than just to get rid of the pain. The pain can go away very quickly, but it's the function you've got to really work on in the medium and then the long term. And there's a whole lot of other things going on in the groin. There's hidden hernias. There's a footballer's hernia, things called Gilmore's groin. The list is a mile long. You can get stress fractures in the neck of the femur. That's a very, it's a serious injury, as you can imagine, and that'll have a different behaviour of pain to these soft tissue injuries. So in younger athletes, it's more common for them to avulse bone, so they'll get avulsions around the pelvis in an acute injury around the groin. So they're the sort of things you've got to watch out for. The typical groin thing, very, very common in AFL, soccer, anywhere where there's change of direction or kicking, the adductors are vulnerable, and then you can get this cascade of injuries going on from those when they're poorly rehabilitated. So that adductor injury, you can grade them, and you've got to manage that acute injury fully, regain the full range of motion in the hip joint. When the player starts to lose their rotation in the hip joint, they become vulnerable to chronic adductor injury and chronic groin pain. Right, the chronic ones are the tendinopathies, similar to the hamstring. The higher up it is, the closer to the bony attachment it is, the more serious, the longer it's going to take to rehabilitate, the more likely it is to become chronic. So you've got to do a lot of work strengthening those adductors, strengthening the core, and you need to address the impairments. The impairments will be things like restricted rotation of the hip. They might have other impairments like poor glutes. Poor glutes are really, you wouldn't think so, but poor gluteal activation is really, really common in athletes who've been injured. Their glutes shut down very, very quickly. And if they don't get them working again, it can lead to chronic problems. So the whole thing with steroid injections, and you'll read about different injections, calf's blood, vitamin C injections, and all these things. People going to Europe to see some doctor to get special injections. All these things are unproven. You'll read about it in the media, you'll hear about it. Steroid injections, we know a little bit more about. Corticosteroid is a very effective painkiller, so it will kill off the pain, but it won't really help the problem in the long term. The problem with the steroid injections is that it kills the pain off so effectively that that player can't feel the pain at all, and they keep doing all the things that are aggravating in the first place. So they're usually worse off in the long term. And that's really common with adductor injury, hamstring injury, and the hip tendon injuries that we'll talk about later. There's a certain kind of geographical influence here that if you live in Sydney and you're a rugby league player and you've got chronic groin pain, you're much more likely to have a adductor tenotomy operation than if you live in Melbourne or somewhere else. So depending on where you live, the sort of fashion is this tendon release surgery is really common in Brisbane and Sydney, not so common here. So basically what happens with that is you've got chronic tendinopathy in the adductor longus, and that surgeon just goes in and cuts it. And it's a tenotomy, they cut it, stops the pain. The player certainly is going to pay the price for that in the long term, and it's usually an injury on the other side, or chronic groin pain or something like that, hip arthritis in the long term. All right, FAI, it's really sort of the popular thing, popular topic. That's femoroacetabular impingement, yeah? You can have, two different types, essentially. There's the cam impingement, where you have an extra bit of bone growing in this junction between the head and the neck of the femur. And you've got this bump on the bone that you get impact at the edge of the acetabulum. That damages the labrum there, and in the long term can cause damage to the hip joint, to the articular cartilage. Pincer impingement is where you have too much overhang, or you have this extended edge of the acetabulum, and you get impingement because of that. And you basically this triangular area where the labrum is gets smashed, repeatedly. You get the degenerative labral tear that goes with the FAI, and you have a combination of both, or mixed picture. Now, why this happens is it's an imperfection of the fit of the ball in the socket. So not everyone has a perfect spherical head of the femur. In fact, very few people have. And depending on how imperfect the fit is, that person will be more vulnerable to these types of femoroacetabular impingement. You can have a really shallow socket and the hip joint will be a little bit unstable. That's more common in females who are really mobile and they've got hypermobile joints. In men, it's the other way around. Usually their hips are a lot tighter and they've got less range of motion, and they're more likely to have this sort of FAI impingement. There's a high incidence of this in people who don't have any pain in their hip. So people can have an x-ray of their hip. It looks like they've got FAI, but they don't have any symptoms. It depends then what you do, what sport you play. If you play a sport where you're flexing, adducting, or internally rotating your hip, so that FADDIR or fadir position, like kicking the ball across your body a lot, or you're a cyclist where you're doing a lot of flexion, or a rower where you're going into a lot of internal rotation and flexion all the time, that causes damage. So wear and tear, that impact at the edge of the acetabulum causes the wear and tear and the damage, and the pain will be in the groin, deep in the groin. So when it's deep in the groin, it's the hip joint. It will radiate down the front of the thigh to the knee, but it won't usually go below the knee, and it won't be on the outside. It won't be in the buttock. So typically it'll be deep groin pain when the person's sitting or putting their hip into flexion, adduction, internal rotation. Okay, that's the main test and the main clinical story. It can be the labrum itself is like a cartilage in the knee. It can be torn acutely, and that's actually really common in a fall. A cyclist who falls on the hip can tear their labrum, and it won't show itself till months or years later, after they've recovered from the acute injury. Why truck drivers? They jump down from their cabin down onto the road. Usually about sometimes 2 metres high, and they just keep impacting their hips. So OH nesting with truck drivers is they have to step down off the truck, not jump. Now, when someone's got an acute labral injury, like an acute cartilage tear, they'll get signs of internal derangement, like they have what we talked about in the knee. So clicking, jamming, sharp pains, and giving way of the hip. So they might step onto the leg, stand up, step onto the leg, and the hip causes, sometimes the hip doesn't even hurt, but it gives way. But often it's with a sharp pain. People might have an audible click. And that's a bit different to the clunk. There's a click and a clunk for me. The clunk that some people get when they have a snapping tendon around the hip is different to the deep clicking, articulate click that they get inside the knee. And that click's got to be something that's associated with their symptoms. Everyone's got clicking joints, right? But it's got to be associated with their pain and their recent problem. And, FAI and hip joint is a common cause of chronic back pain, because if you're carrying this thing in your hip, it actually alters the way you move and the way you walk in the long term, and then throws stress all over the body, but typically into the lower back. So someone might have some groin pain, it might not be that severe, it recovers a bit, but it changes the way they move and they walk, and it throws stress on the back. And I've seen lots of people who have been treated forever for sciatica or whatever's going on with their back, and you do a simple examination of the hip and find that restriction in flexion, adduction, internal rotation, they've actually got a hip joint problem that's driving their gluteal pain or their back pain. Okay, labral tears, if they're acute and they're causing symptoms, there's this sort of, I guess the most popular thing now is to have a hip scope or arthroscopic surgery of the hip. So I've been into theatre and watched one of those. The leg gets put in traction, so there's a boot put on the leg. The person's lying on their side, and the orderly's basically winding the leg up into traction to get separation of the joint. So that person can wake up with a paralysed foot. They can get a nerve injury in the foot. They get a lot of pain from that traction that happens during the scope. The recovery, like with knee arthroscopy, the recovery is about 5 or 6 weeks for the healing, but the rehab is much, much longer because they've usually lost a lot of rotation in their hip. And one of the complications following a hip scope is people can get a kind of a synovitis and lose all rotation in their hip. And that's a really bad complication after hip scopes. So some people don't do that well after hip scopes. Men seem to do a little bit better than women. Women who have got a hidden instability in the hip joint, they don't do that well when parts of the hip mechanism are taken away, in an arthroscopic debridement. But we've got to go for the gluteal muscle strength is a key thing in the rehab, functional strength, range of motion. And there's this idea that your FAI and your labral tear is your hallmark that you're going to get hip OA in the long term. Again, this is sort of unproven, but the idea that you can prevent hip osteoarthritis by having a hip scope when you're younger, that's sort of an idea that's not really proven. But that early damage could be a sign that that person may develop arthritis later on. All right, there's heaps of other causes of groin pain, yeah? You need to look all these things up. Osteitis pubis is one that's talked about a lot in the media. What that is, it's bone stress where the pubic symphysis meets, the superior and inferior pubic rami come in, and you see bone bruising and bone edema there, usually because the hip joints are stiff and there's too much mobility in the pubic symphysis. So you've got this extra mobility there that shouldn't be there. Stress fractures can happen in the pubic ramus, the neck of the femur. I'll show you a couple of images of that in a minute. Really important to, they have to be picked up because a neck of femur can snap all the way through and then it's a fractured neck of femur in a young person. It's a disaster. So it'll have that bone pattern. So not too bad when you first wake up in the morning. As the person's walking on, they're limping. The limp is getting worse and worse and worse. The deep groin pain is getting worse, eased by rest. There'll be some history of spike in impact load. So that person has started, I've seen a couple of girls who up there running very, very quickly. They're training for a half marathon or whatever they're training for. They up their training load very, very, very quickly, and they started to develop the deep groin pain, and it was insidious. There wasn't an injury, like there wasn't a twist or a fall or anything to bring it on. Psoas syndrome or tight hip flexors, that gets talked about a lot. A lot of athletes complain of tight hip flexors. Some of you guys who are into sport, you've got tight hip flexors all the time. The tight hip flexors are a reaction to something else. Okay, there's something else going on underneath the iliopsoas complex to make them feel tight all the time or to tighten up. So just massaging the psoas all the time and stretching it out isn't the answer in the long term. There's usually something else going on underneath it, and it's usually something going on for restriction in the hip joint or poor gluteals that throw more stress onto the muscles at the front. All right, so your other cause of groin pain in athletes, they could have early OA, so they'll have that real restriction when they get out of bed. They could have referred pain from the lumbar spine, but usually if it's referred, it'll be in a spiral pattern like that. So it'll go to the back, here, and then around to the front, not usually straight in the front. If it's straight in the front and straight down the leg, it's the hip joint. It's not really anything else. Okay, here's a bone scan. Hang on, stress fractures in athletes. So we talked about that. They could have restricted hip rotation or something down the kinetic chain that's causing an increased load to that leg, like a poorly rehabilitated ankle or a poorly rehabilitated knee or something. Here's the hot spot down the bottom. A bone scan is a type of X-ray or scan. Does everyone know what a bone scan is or not? Okay. You get injected with a radioactive isotope and you go into the scanner. Where bone is being turned over quickly, you light up. So that's why bone scans are used to find bone cancer. That's the probably most common reason why people have bone scans, or to look for stress fractures, and you'll see a hot spot on the scan where bone is being turned over quickly. So it's very, very sensitive. It'll find the bone stress very quickly. It doesn't tell you how long it's been there. It could have been there for months, and it stays hot on the bone scan for at least 6 months after it's healed. So it's very sensitive to this turnover. So it gives us an indication quickly if there's bone stress, but it doesn't really tell us the severity of it or how long it's been there. The next thing you go to is an MRI, and the MRI in a T2 weighted image fluid shows white. So that will show bone bruising. Again, it'll show bone stress very, very quickly, very early in the piece. So when you see the white area on the T2 weighted image, that's bone bruising. It doesn't say how bad it is, it doesn't say how long it's been there, but it gives us a localization. So this is a terrible injury. It's a stress fracture in the neck of the femur, right? And it wouldn't take much, as you can imagine, to make that a complete fracture. So that's probably a young person And they need to go on crutches and take the weight off that bone quickly so it gets a chance to settle and heal. So the thing with MRI is there's no radiation. With a bone scan, there's a lot of radiation, like with a CT scan. So people are having bone scans more often now, MRIs more commonly now to investigate bone stress than bone scans. Osteitis pubis, we talked about it before, it's also stress to the bone. That person will have tenderness right on the pubic symphysis. There are different clinical tests we can do. I'm going to show you a couple of them. It's one of the worst injuries because it takes the longest time to recover. So usually osteitis pubis is a season-ending injury. So it can happen often in pre-season as that player starts their running program. They may be carrying something from the previous season, like a poor ankle or something going on in the hip, and they will get osteitis pubis, which is the deep anterior groin pain. It radiates up into the abdomen, it radiates down the medial thighs as well. And it's often a slow burning sort of hidden injury in people, but when it gets acute, they can't play with that, and it takes them, a whole season to recover. There's a funny one because even though it's bone pain, they do have a lot of pain and stiffness in the morning. So it's like the bone, I hesitate to say this, but it's like the bone gets inflamed. So it's a really unusual presentation, a typical presentation. There's a test which is the squeeze test that's commonly used, which is basically just squeezing the legs together, and that will usually reproduce the pain. And they'll have guarding in the muscles there, and they'll have the typical findings on imaging. The player first notices they're really, really tight and stiff during and after the activity, and some of the really typical early warning signs is they just seem to be losing speed, losing the ability to accelerate, and losing their kicking distance. In AFL, it's a really sort of common set of early warning signs. And I know a lot of teams now, they regularly measure how strong somebody is on it. The players are once a week or something, they monitor it. And when players are starting to lose their adductor power in that squeeze test, they actually modify their training in an attempt to prevent them getting osteitis pubis. Yeah, that's Peter Bruckner showing the squeeze test. It's often used now to help monitor player load in professional sports. So the X-ray, you get this typical, what they call moth-eaten appearance there. Spiky sort of looking bone. On a bone scan, that's an MRI, you'll see the white area, which is the bone bruising, and the pubic symphysis. You'll see widening of the pubic symphysis and these little cysts, bone cysts as well, or erosions. All right. So the management of the osteitis pubis is to, if they're full blown, they're going to stop. They have to stop, reduce the loads, and motor relearning. Again, it's usually about the core and the glutes. Get them going again. Gradually resume the running and the kicking. But the rehab is really long. So there are some physios who specialise in this. There's sort of groin rehab. You can find out about them and read about them. Watch out for kids with anything around the pelvis or groin. They're much likely to pull off bone. So there are about 14 different areas around the pelvis where you can get an avulsion injury. The iliac crest, the front of the pelvis, the anterior superior iliac spine, which is some origin of different muscles there. The great trochanter, the ischial tuberosity, where the hamstrings originate from, can actually pull off, and that's an avulsion injury of the proximal hamstring in a younger. Sometimes it's a guy in his mid-20s, so that ischial tuberosity sometimes doesn't fully join until the early 20s, so that can pull off. And there are some other ones there. So watch out for those in a young athlete an adolescent or a teenager, they're much more likely to have this than anything else. Yeah.
What like symptoms for the ASIs and AIIs?
Okay, they'll usually remember a moment when it happened. So they'll be sprinting and they'll feel a pull, right? And then they'll be limping. Okay, whichever one of these it is, maybe the exception would be the iliac crestis. There'll be something going on with their gait. So it'll be a kid, a teenage kid, they're walking, they're limping. Right? They might not be in that much pain because it's a complete injury, like we were saying the other day. When you go to examine them and you test that muscle, there's zero power, right? Because it's not joined anymore. So do you know how to isolate rectus femoris? Do you know how to isolate a sartorius muscle? This is where you've got to know your anatomy and your functional anatomy. When you go, you can do all these other tests and everything's fine. You isolate that muscle, zero power. Anyway, you already know that you've got to send them for an X-ray because they're a kid, and you know it's pretty much mandatory that you've got to check that they don't have an avulsion. Is that okay? Okay, let's go on to OA. This is, you know, you're going to have a career, some of you, looking after people with OA in the hip. Okay, again, if it's osteoarthritis in the hip, it'll be groin pain, right? Groin pain. They're going to wake in the morning with severe morning stiffness, so really struggling to get out of bed and hobbling and limping, yeah? Okay, the main thing with OA in the hip is the loss of mobility in the hip joint. So they lose their rotation first. The most sensitive movement is internal rotation. So they lose their internal rotation, their external rotation, their combined favour, right? They lose their combined movements. Then they lose extension, then they lose flexion. So they get this global loss of movement. You've got the capsular irritation, which is sort of the inflammatory part. Cartilage can't feel pain. It's got no nerves in it. Cartilage doesn't get inflamed. So cartilage can be worn down to bone and it won't hurt. It's only when you've got the secondary things going on, like the capsular irritation or the bone pressure, like when the cartilage is denuded, then there's more pressure on the bone and bone can feel pain. So once you get to the bone on bone, then the pain becomes very severe. So they'll be limping, they'll be their sport, if they're a young athlete or a middle-aged sort of athlete or a social athlete, their performance will start to be affected. Because of the lack of movement, they might start to get other things going on, like knee pain or back pain. That might present the same. You know, the first thing that might present is back pain, actually. And you look at the hip, and they've got hip arthritis, and actually the first thing they get is back pain. So it's progressively worsening, and you don't really have a diagnosis of OA until you do an X-ray. So OA is really a kind of a radiological and clinical diagnosis. So the typical things you're going to see, the reduced joint space, yeah, bone to bone. Then you see the sclerosis, or the sort of the polishing of the bone, where it gets hard and really dense. That's the sclerosis. And then underneath you see the cysts, the holes, and the subchondral bone cysts. So that means it's pretty far gone, and you've got this thing where you've got bone on bone on the X-ray. And usually the shape of the head of the femur is getting flattened. So instead of a spherical ball to be the head of the femur, it's a bit egg-shaped and it's a bit flattened out. So you examine these people after they've told you all this, and they're going to have a restricted and a painful hip, active range of motion and passive range of motion, particularly those two movements that I talked about. Their gait, they'll be limping. All right, you see this out on, you know, if you go to the mall or wherever, you'll see people limping. They'll have a waddling gait, or they're sort of flexed in one leg, and they've definitely got a limp going there because they can't, usually because they can't extend their hip fully. They're walking with a slightly flexed hip and flexed knee. Their stride length will be decreased, and they'll really struggle to walk. Muscles get really tight all over. The quads will atrophy, the glutes will atrophy. So with the knee, the number one thing is the quads atrophy, and then the glutes. In the hip, it's the other way around. Like the glutes atrophy first, and then the quads. Yeah. Right. If someone's a bit younger and they're not going to go and have surgery on the hip, the conservative, you can help people quite a lot by regaining their movement and regaining their muscles. Right. So there's two things you definitely can do to help people with hip arthritis, and that's conservative. They don't have to have surgery. You can see how much you can help them by getting their muscles going, then their movement back. Stretch out the tight muscles. Alright, now it could be that it's bone on bone, and whatever you do isn't going to help them enough, and they're going to be, usually they're referred by their GP to go and see a hip orthopaedic surgeon. Sometimes that happens to you in the middle of the rehab. Suddenly they've gone off to see the orthopaedic surgeon, and they're going to have a hip operation, and you're sort of going, oh, I thought I was going to help you with the physio. That's quite a common thing. But even if they are going to have an operation, the better their muscles can be and the better movement they have beforehand, the better they will do after. So hip replacement surgery, total hip replacement, is the most common orthopaedic surgeon, is the most common operation done in Australia. It's very, very successful. There's thousands of them done, every year. Mostly they're total hip replacements, so the whole joint is replaced, the ball and the socket. But very rarely there'll be a partial hip replacement where only the ball is replaced. So just the cap where the ball is replaced, the socket might still be in good condition. One of the reasons why someone might have a partial is because they're a younger person. Because like we said, I think we said with the knees, these things don't last forever, even though they're made out of titanium. They have a use by, and usually it's about 15 years, 10 or 15 years. What do you think, Phil? How many of you seen that have gone longer than that?
Not many.
Yeah.
Not many.
I've got one lady who's had one for 20 years. That's really the exception, and they usually only last about 10 or 15 years.
They often always used to say 15 was the max.
Yeah. So if you're sort of, we expect to live into our 80s, at least. So if you're in your sort of late 50s or early 60s, you want to avoid having to have two, because the second time you have a total hip replacement, there's basically nothing left because the whole head of the neck and head gets chopped off and the whole acetabulum gets taken out and replaced. So to do that again, you actually have to have much more extensive surgery, and the shaft of the femur has to, to have good bone stock so they can replace and put in a new shaft and everything like that. So it's about preserving or keeping that person functionally going and pain-free as long as possible, avoiding surgery if possible for as long as possible. Right, so here is a resurfacing, and the most common one of those is called a Birmingham, where they just sort of shave off the whole top of the head of the femur, which is misshapen and abnormal anyway, and put a new cap on there. And a total hip replacement, they cut off the whole neck and head and remount the acetabulum and put in a new cup and put in a new whole head of the femur, neck of femur, and there's usually a metal spike, if you like, that goes down quite deep into the femur. So here are the partials, just the cap part. The neck of femur is preserved there, yeah? And here is total hip replacement. There's a plastic cap there, which is why you can't. It seems lucent on the X-ray, and this spike that goes down into the shaft of the femur. There's a couple of different. Sometimes they're cemented in, and the bone. There's all kinds of issues with the bone cement. People can reject the bone cement, and you get all kinds of problems with that. Or it can be uncemented, where it's basically banged in, like with a hammer. So I've seen a hip replacement operation a couple of times, a couple of different methods. It's pretty brutal stuff. So to get the head out, the orthopedic surgeon and his assistant had to dislocate that person's hip. So they put it in flexion, the person's on their side, flexion, adduction, and internal rotation, and dislocate. So one of the first things they have to do is get the head out, and they chop the head off, and then they ring out the thing. Now, I'm telling you, not to get you upset, but I'm telling you because as a physio, you have to understand that flexion, adduction, internal rotation movement is a contraindicated movement in the rehab, because as that person's hip has become dislocated, the capsule has been damaged and their muscles have been damaged, so that position there is banned in the rehab. So when that person wakes up, they've got a pillow between their legs to keep their legs apart. This is for a posterolateral hip replacement. It's not all hip replacements, but it's the most common one. So this is going to be hammered into you when you go and start to work with people in the hospitals about those contraindicated movements. Flexion, adduction, internal rotation is banned as a movement in the rehab, and that's one of the things you've got to be very careful of when you're getting people up out of bed and getting them moving. So the anterior approach is what's called the minimally invasive approach. It's still, brutal stuff, but the surgeon comes in from the front instead of the back. The hip is dislocated in a different way. It's dislocated anteriorly, so the contraindications are the reverse. Now you've got to do your reading and look up what are the contraindications for an anterior hip replacement. And there's less muscle damage, and there's sort of more and more of these anterior hip replacements being done. Your job as the physio is to restore that person's function, restore their gait. It may have been abnormal for a really long time, and you've got to get their gait normalised again. Or they'll start to get problems. They'll start to wear out their other hip or their knee or something else. You've got to improve that after that hip replacement. That person's gone through a lot to have that operation, and the trauma of it and the rehabilitation. You've got to restore that person's quality of life, and that's a really important job. I always say the operation is only 50% of the result. If you have you can have the best surgeon, the best operation in the world, but if you have poor rehab, you'll have a poor result. Okay, the last thing is a pet topic of mine, and it's not trochanteric bursitis. Usually, the cause of lateral hip pain is gluteus medius tendinopathy. Bursitis is a myth, and it's the old school diagnosis. The actual diagnosis for people with lateral hip pain is gluteal tendinopathy. Yeah. So you know what the bursae are in the, they're basically just membranes, and if you dissect down and look, they look like glad wrap. They're sort of little sheets of glad wrap with a little thin layer of fluid in between. There's not much to them, right? They don't have, they're there to stop friction. They don't have a huge functional role. But what happens is the bursae that lie between the tendons, when the tendons are damaged and become thickened, there's more pressure on those bursae and they become hypertrophied and they build up with fluid. But the bursitis is not the diagnosis. It's secondary to the tendinopathy. All right, so this lateral hip pain or buttock pain is super common, right? It's more common in women than in men, and it's usually in women who are quite active. They're trying to exercise, or they've gone on an exercise binge, or they've taken up something, or they've gone on a big travel overseas or something like that, and they've suddenly increased the amount they're walking or the amount they're doing, and they damage their tendon. It's usually women in their mid-50s, in the 50s. 1 in 4 women in their 50s have got a degree of gluteal tendinopathy. That's an epidemiological study by Siegel et al. So the conditions are there for them to damage their tendon. Why women more than men? We can talk about it in a bit more detail another time. But men get this going in their Achilles. It's men who get Achilles tendinopathy.